So next, I'd like to introduce Jeffrey Norton, who will talk. We talked a little bit about surgery here. We're going to talk about novel surgical options. Jeffrey Norton, welcome.
Thank you very much. So I think questions you should ask your surgeon when you meet your surgeon is some of the questions I've kind of written down here. What kind of surgery do you recommend? I think a critical element in the surgery is to get negative margins, which means we try to transect or cut the stomach 5 centimeters proximal to the tumor. What is the most common complication? The biggest complication would be a leak where we sew the stomach or the esophagus that remains back into the intestine. What is the chance of death? The death rate with surgery of the stomach nowadays is relatively low. I would say it's like 1% or less. How will I feel after surgery? I think that you should feel relatively normal and you should be able to eat relatively normal, but you may have to eat more frequent small meals. And if I have pain, how will you control it? There's a lot of ways to control pain, like a PCA, which is patient-controlled analgesia, which means you push a button and get like morphine or Dilaudid, or an epidural. So we use epidurals a lot. And so an epidural is a special catheter that they put in the epidural space, which will allow you to have surgery with no pain. And we leave it in for like 4 or 5 days afterward. You can still walk around, breathe. It's pretty much a miracle, and I think most major hospitals use that now, as long as you can place the catheter in the correct place. How long will I be in a hospital? Usually about a week or 5 days, 5 days to 7 days. And am I likely to have eating problems? I think most patients do have eating problems, but they learn how to eat in relation to themselves, and they learn what to eat and what not to eat. So I think from the long-term perspective, they actually do fairly well. One thing, I think you do need vitamin B12 shots. It's absorbed in the stomach, so you have to have vitamin B12 shots after stomach surgery. Negative margins is critical during the surgery, and we do D2 lymph node dissection, which means we try to remove all the lymph nodes around the stomach and also the greater omentum. It's been shown in studies that patients actually do better if you do D2 lymph node dissections. It's been shown that they have higher complications with that, but they actually have better survival. And I think that we can do D2 lymph node dissections very well. It means that we remove all the lymph nodes that he showed in the prior slide. And also during the surgery, we get negative margins, which means that the pathologist, we have to wait. We cut the stomach in an area where we think there's no tumor. The pathologist looks at it under the microscope, and we wait and hear what the margins are, whether there's tumor at those margins or not. There needs to be no tumor. We've actually just published a paper where we're using mass spectroscopy to replace the pathologic analysis of margins, and it's an experimental study, but it looks promising. This is actually kind of some of the ways we take the stomach out for surgery. In this particular diagram, you can see that the tumor is in the distal stomach, what we call the antrum, and so we resect the antrum. We try to go 5 centimeters proximal to the tumor. That's where we cut the stomach proximal toward the mouth, and we remove all the lymph nodes in that area, and the lymph nodes are along the left gastric artery and also the greater omentum. And this actually shows you how we would hook it back up after that type of resection. This is one way to do it. Another way would be Roux-en-Y, which actually may be better because it would have less bile going into the stomach, which I think is an advantage. If the tumor is in the more proximal stomach, like the cardia up by the heart, then we actually have to do a total gastrectomy, which means remove the whole stomach, and we actually make a small pouch out of the, it doesn't show it in this diagram, but we make a pouch out of the jejunum, which we sew to the esophagus. And of course, This type of surgery is associated with worse eating, but if the tumor involves the whole stomach, this is what needs to be done. And then I also have a slide to show like the more proximal tumors and what we call an Ivor-Lewis esophago-gastrectomy, which means we actually take out the more proximal part of the stomach, and then we actually bring up the distal stomach and sew it to the esophagus and the chest. This is a group of patients. We've had 27 patients with CDH1 mutations. That's hereditary diffuse gastric cancer. I've done surgery on all these patients. Basically, this is actually linitis plastica, and it means that the tumor kind of is diffusely in the wall of the stomach. They need to have total gastrectomies. And actually, in this particular group of patients, they inherit this CDH1 mutation, and it's pretty clear that when we study them, including endoscopy with multiple biopsies, PET scan, CT scan, and just about every study we do, we cannot prove that they have cancer. So it's a little bit of a leap of faith. And when we first started to do these patients, we thought the probability of them having cancer with this mutation was about 60% to 70%. It turns out every single patient we've done has had cancer in the wall of the stomach. So I think that these patients have all had total gastrectomy, which means that their whole stomach was removed as well as D2 lymph nodes. We usually get about 30 lymph nodes in the specimen. No patient ever had lymph node metastases, so they had no additional treatment besides surgery. So I'm going to show you exactly how patients do after total gastrectomy. We could have the slide.
Matt, first, what would you do if you discovered that you had carried a mutated gene for a very rare, aggressive form of cancer, and that this gene would probably lead to that cancer? Well, 11 cousins faced that very question, and they each made a very radical decision. In 1960, Golda Bradfield died of stomach cancer, leaving behind an unfortunate legacy. At least 6 of her 8 children inherited her mutated gene. The same cancer killed all of them, but not before passing the gene along to their children.
It's about 3% of all gastric cancers. It is associated with a specific gene mutation, and it's very aggressive.
22,000 Americans will be diagnosed with stomach cancer this year. Half of them will die. For the Bradfield cousins, the risk was even higher. Through genetic testing, 11 of Golda's grandchildren learned they had inherited the gene. With up to an 80% chance of developing cancer, one by one, they decided to have their stomachs removed.
This is really the first time this has ever happened for such a major organ like the stomach.
Dr. Jeff Norton performed the surgery on 6 of the Bradfield cousins at Standford Medical Center in California.
It would be a big gamble for them to wait, because if they developed stomach cancer that was macroscopic or large, they would have probably had lymph node metastases and would have died.
In fact, Dr. Norton says each of the stomachs he removed showed early signs of cancer, signs that went undetected before the surgeries.
The chance of them being cured was very high, so we feel like we intervened at exactly the right time.
Many of the cousins who recently reunited in Las Vegas never knew each other before their elective surgeries. Now they're bonded by common experience and the hope for a healthy future. And joining us right now, I'm going to introduce everybody. Tell me if I leave anyone out, because I have a big, long list of names. We've got Mark Allen, Linda Bradfield, Rita C. Marie, sisters Kathy Elliott, Connie Gassaway, Diane Sent, and siblings Jeannie Maccabee and Ted Specht and Bill Bradfield. Did I get everybody? Yeah. Oh, go ahead. And Mark and Laura, we're going to kind of ask you guys to sort of speak on everyone's behalf as well. It's nice to have you all here.
Thank you.
And let me just get kind of a sense. Everyone in the group has had surgery to remove your stomach, right? Right. And let me ask you, with a show of hands, after you had the surgery done, how many were found to have had cancer or an early form of cancer?
So they actually all had cancer.
Everybody but one of you, yeah?
Yeah, we all did.
Or at least in what doctors believe might lead to cancer, right? Anybody here hesitate about having the surgery? No, not at all. Pretty universal on that front. Right. Laura, you cousins were not really all that close before this your history, I guess, brought you together,
Right, we were very spread out. Kitty actually lives in South Africa, and then most of the rest of us are spread out across the country. Several live in California, but East Coast.
Yeah. And your cousin David died of stomach cancer.
Yeah, David Allen. He was the one that they
Everybody
discovered
who
the
presented with
mutation.
symptoms ended
A
up
mutated
dying.
gene.
Correct.
And his wife, through genetic testing, shared that with you all.
Right, once she was told that she wanted us to know that we had the possibility of possessing the mutation.
Which led to everyone going to get tested.
Right.
And what do you think would have happened had you all not acted?
I feel like I might not be here now because my doctor did actually, Dr. Kuby found that I did have cancer that we did not know about, that I had no signs or symptoms. So it was very fortunate
actually the first
that
one that got
we had this
operated on.
surgery and I don't have to worry about that possibility.
And we should be clear with people, stomach cancer is deadly.
Right, most of the time
people don't survive.
Right, by the time you have signs or symptoms, it's too late.
And this gene was prevalent in pretty much all of the cousins, correct?
Right, 12 out of 19 in this generation had the mutation.
It's a 50%
So, Michael,
probability.
let me ask
that
you,
we
I mean,
get the gene.
having your stomach removed, most of us obviously can't even imagine. What does that mean for you? What can you eat? Can you digest food properly? What's your life like?
Sure, it's really not all that different, except I have to chew food a little more and take smaller bites.
And I guess eat smaller meals, kind of?
Initially, you have to eat many times a day.
I think the stomach
Laura, do
actually
you think it's
adapts.
changed
I
your
mean,
life
the
a lot?
genome adapts.
All of us have to eat a little
They
less sugar,
substitute
which is a good
food,
thing because we've lost a lot of weight. Between all 11 of us, we've lost over 600 pounds.
There you go.
So we eat a lot less sugar
A lot of weight.
and just a little bit slower and more often.
I know we've got a picture of you, Laura, before the surgery as well.
Okay.
So
they
you
were all
do.
pretty heavy
Everybody
before
in the
that.
family has lost a lot of weight because of this. I'm
Pretty
guessing.
much, yes.
And I have to ask you, Laura, as well, I know through the genetic testing you have also discovered that you may have a higher risk of breast cancer
Yeah,
as
they
well.
also get
Women, we have a
lobular breast
39%
cancer.
chance
The
of
risk is
developing lobular breast
40%.
cancer, so we're all trying to be very careful with that and monitor that every 6 months.
And I know you're thinking about possibly having your breast removed again as a preventive
Right.
measure.
That's a possibility that we've all discussed, and it may be something that some of us choose to do.
Do you think, Mike, you address this, that surgery, going through this, has sort of changed your outlook on life? I mean, given your history, and you all knew what it was, I mean, so many people in your family lost to stomach cancer, that in a way you're living, I would assume, almost assuming that you're going to die from this at some point.
Many of us had that end in mind, yes.
And you?
Oh, I just...
Anybody else want to jump in? Yeah? And what about now? I know you all had a reunion in Las Vegas, kind of in an odd way, I guess you are celebrating this moment. Probably not a lot of eating at the reunion, I'm guessing, but...
We had a great time, just celebrating every day. Every day is a gift to us.
Well, it is, absolutely. Well, we appreciate you all coming on and sharing. It really is extraordinary to have so many in a family go through something like this, and we wish you all the best of health, certainly.
Thank you.
So I think, in conclusion, I think that surgery can be done. It requires complete removal of all tumor with negative margins, and I think the attention to the lymph node dissection is important. And the complications can be large, but basically we kind of are able to avoid complications. We have special instruments to do this. This is actually starting to be done laparoscopically. It's also being done open. The eating pattern is clearly changed by this. There's no question that this affects your ability to eat, but I think that if the tumor is the rate limiting step on the quality of life and survival. That's my opinion, and not so much the surgery. Thank you very much.
Thank you very much, and I thought that video was, I had never seen that video, so thank you so much for sharing that with us. Do we have any questions? We have a question up here in the front. We have another one over there as well.
Thank you so much for that. My husband was diagnosed with Lionitis plastica 2 years ago, and He actually shouldn't even be sitting here. They did the CDH1 testing because his tumor carried the protein, but he does not have the CDH1 gene, thank God. However, we do have 5 children, and his grandfather died of stomach cancer. They don't know if he had linodysplastic or not. Tony did have nodes that were positive. My question is there other genetic testing that you're aware of or other tests out there other than CDH1 that linodysplastica may give out that we could be proactive for?
Yeah, I think that, where was he tested? Let me ask you that.
What hospital?
Yeah.
Duke.
Duke?
Yeah.
So that should be good testing. So I think that it sounds like he might just have the protein, like you said, and not the gene defect. You're right that the type of tumors you get with this is what they call linodysplastica. So it's a very significant type of stomach cancer, and it occurs at a young age, too. So I think that it sounds like you really don't have to worry about the children inheriting this. That's what I believe.
Hi, I've been diagnosed stage 4 stomach cancer with the upper portion of my stomach, and no surgery is at this time considered. But I was wondering, do you also do the HIPEC surgery? And,
Yeah, we don't
and
do.
what are your thoughts about that?
Yeah, I think I don't personally do the HIPEC surgery, but I think it's more applicable to pseudomyxoma peritonei. It's more applicable to tumors that are less virulent than stomach cancer. So I would not recommend it for stomach cancer, to be honest with you. But I think that some of the other medical oncologists may have a different opinion. But in general, it's not indicated for stomach cancer.
We have a question up in the, one over here in the front, and we have another one in the front here.
Doctor, as far as lymph node dissection,
Yes.
you mentioned D2. What prompts you to go D2 or no, or when you're in surgery, you will
Well, I
know.
always do it the same exact way every single time, but it depends on really knowing the anatomy. I think the radiation oncologist showed exactly how the anatomy is, so you have to just know the anatomy. And once you know the anatomy, it's not really that difficult to do a D2 lymph node dissection.
And how many lymph nodes are you talking about?
Usually you remove between 30 and 40 lymph nodes.
30 and 40?
Yeah. And of course, the number of lymph nodes is dependent not only on the surgeon but the pathologist, but you can remove a lot of lymph nodes when you remove the stomach.
We have a question here in the front.
I have 2 questions. The first has to do with surgical complications. There are 2, of course, the most significant is leakage, which you described. There are 2 other complications that I experienced that I didn't feel were properly disclosed that maybe you could comment on. One has to do with stricture, and the other has to do with incisional hernias. Do you run into that much, and are they correlated in any way with open versus laparoscopic versus robotic surgery?
Well, if you have like a total gastrectomy, I think that stricture is a possibility. It's got to do with the size stapler you use to put it back together. So I always use a 29. I can just tell you exactly how I do it. And if you use a 29, you don't get a stricture. If you use a 25, you do get strictures, and that affects the quality of the way the person swallows. So I actually haven't had strictures because I use a 29 with a dilator. I think that hernias definitely occur. So they occur more commonly if you have a wound infection. It weakens the fascia. So the definition of a hernia is a defect in the fascia. So you don't need to have the skin. It's not a skin defect. It's a fascial defect. Mm-hmm. And definitely I've had my share of hernias. It's a complication of that type, any type of abdominal surgery.
Do you think that it's highly risky to have those hernias repaired, or is it a common procedure?
It's pretty common procedure to have them repaired. But I think if it bothers you, then it should be repaired. But if it doesn't bother you, if it's a big defect, then it's probably okay not to have it repaired. A big defect means the bowel won't get trapped in it, where a little defect is more worrisome. The bowel gets trapped in it, that might cause like necrosis or death of the body if it gets trapped in there.
Thank you. My second question is a clarification on the CDH1 gene. I had read that the association more had to do with signet ring cancer.
It is. It's signet ring cell adenocarcinoma of the stomach, which actually is the type that develops into Leonitis plastica.
But
That's the most aggressive type of stomach cancer.
I'm a little bit unclear because I was diagnosed with Leonitis plastica and I had a total gastrectomy, but I was never told that I had signet ring.
Well, I think if you go back and look at your stomach specimen, you will have signet ring cells in there.
There will be some. So I
That's-
should be tested for the gene.
Only if you have a good family history. Depends. Not everyone who has, Leonitis plastica has this type of mutation. So it depends a lot on your family history and your age at diagnosis. There are criteria for testing.
Thank you.
Great, thank you. We have a question online here. It's a little long, so bear with me. Would you recommend any possible surgical options, for example, gastrectomy, for someone who is presumed to be stage 4 based on CT findings showing metastatic bone lesions and has been treated effectively with DCF for 1 year without local or metastatic recurrence?
Yeah, have they had like a complete response clinically?
Didn't say.
I think that's, in general, we don't do gastrectomy for stage 4 gastric cancer because, it needs more systemic treatment. I think that occasionally, I'm considered to be a pretty aggressive surgeon, unfortunately. But that might be good or bad, but I have done it sometimes, but only in unusual circumstances when the patient's had a dramatic response and, working with the medical oncologist. And in that setting, I've done it a few times. But in general, you don't do gastrectomies. It's a contraindication, a reason not to do gastrectomies if they have stage 4 disease. Because you wouldn't want the complications to arise. If you try to sew to tumor, it won't heal properly. So that's a big issue.
Great, thank
All right,
you.
thank you very much.
We have a question in the back. We have quite a few questions.
Okay.
Go ahead.
Just a really quick question. In reference to the video, why were these women at a 40% increased chance of breast cancer?
It's related to that same mutation. So the CDH1 mutation is also associated with a relatively rare type of breast cancer called lobular breast cancer. And the best way to diagnose that is MRI. So they're usually followed by MRI instead of just mammogram. And so these particular people were pretty aggressive. We haven't actually done or recommended mastectomy for those patients because, see, the problem is like when we first started that study, we thought the prevalence of stomach cancer was going to be more like 70%, but it turns out it's almost been 100%. There's only one patient, and that's like 5 different families that didn't have stomach cancer. So we're going to learn more about the prevalence also of the lobular breast cancer in those patients. So we're probably going to change our recommendations as time goes on.
Okay, we have one question in the front.
Thank you. With total gastrectomy, can you comment on the risk for E. coli infection in the pouch?
Yeah, I haven't had that problem. I mean, it depends on the pouch. I don't actually do a pouch, so the way I do it wasn't really drawn that way. So it is a pouch, but it's a small pouch. So I don't do the standard big pouch where you try to double the size of so I think most surgeons don't do that anymore. Okay, thank you very much.
Thank you very much for that wonderful presentation.